Welcome to the Neuromodulation podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Welcome to this episode of the Neuromodulation podcast. Joining us today is Dr. Heather Pinckard-Dover, a pioneer in blazing a path for fellow women in neuromodulation. Dr. Pinckard-Dover became the first female neurosurgeon to graduate from the University of Arkansas. She uses cutting-edge tech like DBS and SCS to alleviate chronic pain and movement disorders. Building strong relationships with patients and empowering them through education and advocacy is a passion of hers. She founded the West Virginia Movement Disorder Alliance, a nonprofit that focuses on financial assistance for patients with movement disorders, as well as education and bridging the gap to community support programs. Welcome, Dr. Pinckard-Dover.
Thank you for having me.
Thank you for being here. Today, we're going to be discussing topics of why pursue a career in neuromodulation from a neurosurgeon perspective. Let's dive right in. Could you please start by sharing your personal journey and what drew you to pursue a career in neuromodulation?
Well, my senior year of high school, I was at the Arkansas School for Math and Science, and we had this special class called Biomedical Physics, where we learned about biology and physics at the same time. Our topic was neural networks in biology, and in physics, we were learning about electricity and conduction. And it was a wonderful gap where our biology professor brought in a video and showed us a Parkinson's disease patient that had deep brain stimulation. And I had never seen anything make such a difference in somebody's life. And that's when I knew that's what I wanted to do. So from there, I went to Baylor University and I majored in neuroscience, and then went to medical school at the University of Arkansas and knew that I had to find the functional neurosurgeon as soon as possible. So thankfully, a friend introduced me to Dr. Erica Peterson during my second year, and she took me under her wing and started showing me all the ropes, even in medical school. And then I had the privilege of staying and doing residency with her, and she has really pushed me along in my career, and very thankful for those experiences.
That's wonderful. That's something that's so important in what we do with the INS who sponsors this podcast is the mentorship program, because it's so important to be taking budding neuromodulators and giving them that experience, helping them develop and become leaders. But what specific aspects of neuromodulation attracted you as a neurosurgeon? You touched on that a little bit, but is there more that you could expand upon?
Yeah. So what I love the most about neuromodulation is the difference in the patient's life that it makes immediately. Everything else in neurosurgery that we do, there's a lot of postoperative pain, and it takes a while, and it could take several weeks to months before the patient really fully understands the benefit that they had. And not all of them benefit from the surgery. But with neuromodulation, it happens right there on your operative table or immediately there in the post-op. Patients are crying and just so thankful for the change that you've made. And every visit they come in, they're talking about, that they could now do this that they couldn't do before, and just are so grateful. And that never gets old.
I would say that has to be extremely rewarding.
Yes.
Could you just elaborate a little bit for maybe prospective patients who are listening? What are these types of things that they haven't been able to do before?
So for my movement disorder patients, like with essential tremor, and when we turn their stimulator on and we give them a water bottle to drink from, they will oftentimes start crying because they haven't drank from a bottle without a straw in 10 years.
Oh.
Or my Parkinson's patients will get this just sense of release on that side of the body from the stiffness that they've had for so long. And one person told me, I can actually walk out to my barn now and walk up the hill and not feel so tight. Something I haven't done in 5 years. and it's just been falling down because of it. And so that's in the movement disorder world. In the pain world, I have patients who are telling me, I slept through the night for the first time in years, or I was able to play with my grandkids that I couldn't do before. Then I had a DRG patient who couldn't sit for long periods of time. She couldn't work because of her chronic pelvic pain. And after the DRG stimulation, she came in and was thankful she could work again, and she got her sex life back. And she was able to just recently get married because of that. So those are some of the things that I get to help and are very rewarding.
Yeah, I think people really take for granted just activities of daily living until, as you mentioned, years of them being gone and that quality of life. And I think that they've given up hope that these things can ever be possible again. But that's the beauty of neuromodulation, that they are. And, the title is Why Pursue a Career in Neuromodulation from a Neurosurgeon Perspective. I mean, we could end there. You just nailed it. I mean, you've convinced me. Um, what are some of the challenges or complexities that neurosurgeons face when working with neuromodulation techniques?
I would say the biggest challenge is convincing insurance companies that it's worth it, that their patients need it, and that they should support them in it and pay for it. So many times you have to do appeal after appeal, and then it's heartbreaking when you have something that can help somebody out, but because it's expensive and their insurance won't cover it, you can't offer it to them. And it's so hard. And so we fight the appeal process all the way up. I send every appeal letter comes with all the evidence, the NANS guidelines, up to the director of the insurance, trying to push that they need a change so that hopefully in the future we'll be able to give it to more patients.
Yes, and that speaks to why it's so important to have resources like NANS, because I know that they're so great with advocacy specific to this, and that trying to educate insurance companies the long-term benefit and the ROI is actually going to even be better for the patients. But because some of these are so emerging, we're just not there yet.
Yes.
I just think if they could hear some of these patient stories, you'd hope that would make a difference. How do you see the future of neuromodulation evolving, and what potential benefits or innovations do you anticipate?
I see the future being, one, increasing the different types of pain that we can treat, the different movement disorders, the psychiatric disorders that we can treat with neuromodulation. That's one area that I see a lot of growth in research towards. I see we're already working to miniaturize these devices and make them as least life interfering as possible. And so moving to these small rechargeable devices that only have to be recharged 4 times a year, for
Right.
instance, with one company. That's a technology that I think is very important to move to lessen the inconvenience on day-to-day life. And hopefully one day, actually, I'll be out of a job and we won't need to surgically implant anything, but I doubt I see that in the next 15 years.
Yes. So you mentioned where we are now in terms of the lesser invasive and the battery, but could you go back to where were we before, even just 10 years ago?
Yeah. So 10 years ago was right when I was starting my career. And I remember being so excited because I got to implant the first MRI compatible paddle lead in Arkansas with Dr. Peterson. And now to say that sounds weird, that there were devices that weren't even MRI compatible before. Almost all of them are MRI conditional in some way now. Like I said, they're getting smaller, but more contacts in there so we can direct the stimulation. We've now gone to new waveforms and changing that. And so our understanding of the neurophysiology has expanded a lot in the last 10 years, which has very quickly been taken up by the modulation devices and used to our advantage to help improve pain outcomes.
That's great. It's wonderful. What advice would you give to aspiring neurosurgeons who are considering a career in neuromodulation?
Stick it out. Neurosurgery residency is very tough, especially if you know you want to do neuromodulation. There's a lot of neurosurgery that is not as rewarding in the immediate, but there's still some reward to the spine surgery, definitely to the brain tumor surgeries, to the emergencies. And all of those surgeries help hone your skills because you don't know where the field's going and you don't know what of those skills you're still going to need, as well as you don't know where you're going to end up practicing. I ended up in a spot where I still do a lot of general neurosurgery on top of my functional neurosurgery. So make sure you hone those skills as well. But it is nice to know that you have this nice rewarding field that you're going to concentrate in.
The light at the end of the tunnel, so to speak. Yes.
A very long, dark tunnel. But yes.
So have you ever had patients who their surgeries didn't give them the outcomes of their wishes, who were then able to benefit from neuromodulation technologies?
Yes, I've had several patients who come to me, and one of the benefits of being a neurosurgeon with it is I can look at it and say, yes, I think spinal cord stimulation is for you, or no, you actually have a spinal problem and we need to do the spinal surgery first. Because though the neuromodulation may help with the neuropathic side of it, you have a lot of mechanical pain. You actually have pressure on your nerve root that I worry if it persists there, you could get weakness and other symptoms. And so we need to go do a laminectomy and discectomy, or we need to do a TLIF. And it takes away the mechanical pain, but they may still have some persistent burning pain because no matter what I do as a surgeon, I can't undo whatever damage has already been done to the nerve roots from that persistent pressure, typically for long periods of time before they come and see me. And so oftentimes we'll do the spine surgery first, give them a good 3 months to see where they're at on the healing process. Most of the time, don't need to do anything further, but there are the few patients that still have some persistent burning pain. And then it's nice to have spinal cord stimulation to offer after that.
I think that's an excellent clarification about how neuromodulation is used. Are there any specific skills or qualities you believe are essential for a neurosurgeon pursuing a career in neuromodulation?
You have to be goal-oriented. You have to clearly know what your goals are and be persistent in pursuing them. Like I said, neurosurgery residency is a very long, dark tunnel. That's the best thing I can use to express it. But if you know what the goal is down the road, it helps get you there. And then be a hard worker. There's no way around it. You're always going to be working probably harder than the other people in the hospital. You're going to be there longer, but it's rewarding and it's worth it. And then flexibility. So you always have a plan so that when that plan fails, you have another plan because it always fails. And you have to have this constant flexibility and be able to move from one plan to the next.
Yeah, I can only imagine. In your opinion, what makes neuromodulation a unique and valuable field within neurosurgery?
It's unique in that it gives patients who haven't had a lot of hope again, or movement disorder patients that, they've been taking the medicine and it gave them hope up front, but now it's starting to have side effects, and they hear about deep brain stimulation, but they're like, I'm not so sure about that. You gotta be crazy. You want me awake and you're gonna drill holes in my head. But then they see enough other patients' stories and it does start to give them hope again. And then they go through the process and the hope builds and you can see it building. And there's some excitement and some fear in that first surgery. And then by the second surgery, it's just more excitement. And by the third surgery, they're ecstatic to have their final stage. And then on that post-op visit, it's just a sheer joy.
Yeah. Could you talk a little bit about, I imagine there aren't a ton of you around in your area, and how having the collaboration of being part of a society, NANS and the INS, how that helps maybe someone who is a budding neuromodulator going through the tunnel to really be inspired and keep up to date with the current technologies and sciences.
So NANS was my very first meeting to attend as a resident, and getting to do the hands-on cadaver course was super valuable to me. It was really my first experience working with the cadaver and seeing the multiple different companies all kind of right there together. Yeah, I'd worked with them with Dr. Peterson at different intervals, but usually there was a couple weeks between the different types of implants. So to see the different companies right next to each other and understand the subtle differences between them was nice. And then the networking that I got to do in that first meeting, and Dr. Peterson was great about introducing me to multiple people that now I consider friends and I can walk up to and have conversations with now, has been tremendous. And then when I started my career in West Virginia, well, 3.5, 4 hours down the road is WVU, which is our number one referral place when it's something we can't handle. Well, that's where Dr. Ali Razai and Dr. Conrad are, and it's great because I already have that relationship with them through NANS. So I can call them up and run something by them or say, hey, I've got this patient that I don't have the technology for at my institution, but I know you do there. Would you be willing to see this patient? And typically it's through a telemedicine visit at first because I'm able to give them all the information and then they just have to go up there for the surgery. And then I can help take care of them post-op. So it's great that that relationship was already built through NANS.
Absolutely. Relationships being key. As far as referring physicians and articulating the value of neuromodulation from a neurosurgeon perspective, could you speak a little bit to that?
So I have a lot of pain physicians in my area who do a little bit of trials, but they don't do any permanents. And so they're always looking for a surgeon who's willing to do the permanents. And prior to my arrival there, many of the physicians were like, sure, whatever you trial, it's successful, come over here, I implant it. And they were just the technician to put the device in. So now I come in and I have a more robust discussion with the pain physicians about who I use, why I use them, and we decide together what companies is the best in each individual patient. And then sometimes I get direct referrals to do the trial initially.
Could you explain for our audience, what are you talking about with a trial?
So the trial is where we implant the leads typically minimally invasively with just a needle and threading the wire up. But some patients have anatomy that doesn't allow for a percutaneous implant of the trial, and we have to do a paddle trial, and that requires a neurosurgeon because you actually have to do a laminectomy and place the paddle, and then you tunnel leads out to an external battery, and they get to wear it for a week, and they try it out. They go through multiple programs and see how much pain control that they get. Is it worth the permanent implant? And 90+% say yes. And we go on to permanent implants. And that could be either another percutaneous implant of wires for my older patients who aren't very mobile and have a lot of comorbidities. I still have that option for them. Or the paddle for my younger people that are getting up and moving and they're going to have us for a long time. And I worry about migration over time. Those are people I tend to put a paddle in for the permanent. So as a neurosurgeon, it's nice that I can do either or.
Right.
But not many neurosurgeons learn the percutaneous implant. So I suggest to all neurosurgeons in training, learn how to do the percutaneous implant. It's a great benefit to your practice.
Absolutely. And what a comfort to patients to be able to know that they have that as an option for the trial for something that might sound scary otherwise. And then to see a little bit of the benefit, possibly a little encouragement from family members as well, because you talked about how the patients have benefited and how that's been so rewarding to see. But you mentioned in the case of the husband or grandchildren who are benefiting as well, just because of their loved one having that quality of life improved so much. Collaboration and interdisciplinary teamwork, how does that play a role in the field of neuromodulation? What are the benefits of those partnerships? And maybe talking a little bit about when you are part of a larger institution, then it's a little bit different. But you mentioned when not, that you have these relationships you've developed to be able to help with that.
So that's one of the first things I had to build whenever I started my practice. The neurosurgeon before me that was doing some DBS, he had the referrals from neurology. He would send for a neuropsych eval, but everywhere that I trained was a multidisciplinary team approach. And so I created my team. I got with neurology, I got with neuropsychology, physical therapy, occupational therapy, speech therapy. I laid out and showed them the benefits of DBS and this multidisciplinary approach, some of the red flags that we need to look out for. Maybe this is not a patient to implant. And then once a month, we meet and discuss every patient that gets evaluated by all of those services to decide, are they a candidate for DBS? If so, what target should we select? How should we stage their surgery to really individualize the therapy and maximize their potential for benefit through the process? So that was one of the first things that I set up. And then also meeting with all the pain physicians locally, sitting down, having dinner, allowing them to put a name to a face and letting them know what kind of services I've learned to do and can offer them that they may not have had before. And just being open and communicating and being able to give them my cell phone number and say, look, if you have a patient you're not sure about, give me a call. I'd love to discuss them. And just being open to that collaboration. And it's not a one-way street. You don't just send me people. I also send to you as well. And we work together as a team to benefit these patients.
Right. Not just establishing the relationship, but nurturing the relationship. And not just in the OR and checking in on your patients. It's a lot outside of the hospital setting as well, it sounds like.
Yes. A lot of discussions are had before we ever make it to the operating room.
Do you feel like those discussions, just in the advancements that you mentioned within the last decade, have been a little bit more receptive? People are becoming more aware, maybe not with the term of neuromodulation, but in another podcast episode, we talked about, well, people know what a pacemaker is. They just don't necessarily know what the term is. Are you seeing more of that?
I would say a lot more people know about spinal cord stimulation. For a while, we were on a very positive trajectory with it. I would say the latest articles coming out are starting to put a more negative tone onto it. And when I'm talking about that with other pain physicians or other neurosurgeons, I say you have to look at where that data is coming from. And when we were talking about some of the real world data, there were a lot of physicians who weren't necessarily trained like in residency about neuromodulation that were just saying, okay, you did a trial, it was successful, I'm going to put the paddle in. And those were never great patients to have put it in to begin with. And so then they fail and they're coming back 2 years later and the neurosurgeons having to take the stimulator out and all they ever see are the failures. And then those neurosurgeons say, well, this doesn't work anyways. Well, they probably shouldn't have had it in the first place. It's very important to focus on patient selection up front.
Nice.
And I think that multidisciplinary approach to it help nurture that relationship, that you're not just turning down everybody that they send to you for it, and helps them understand why you turned them down and what you suggest.
Could you expand on that patient selection from a neurosurgeon perspective? What that means? You mentioned that you've had older patients, if that is a concern, comorbidities, obviously patient wishes, just so our audience has an understanding of what that means and why it makes a difference.
Yeah, so I would say it's the whole patient picture, right? Age isn't a cutoff. This comorbidity is not a cutoff. I've got 50-year-olds that have so many comorbidities that they're not a surgical candidate, whereas this 80-year-old who only has one is. So you really have to look at the whole picture. But when you start combining multiple comorbidities together, you really increase the risk of the patient having a bad outcome just right there in your operating room. And so you have to look at it from a surgical perspective, but then you also have to look at it from a psych perspective. Sometimes if you have a real in-depth discussion with the patient about what stimulation is, what it feels like, some people don't do well with the idea of wires implanted inside of their body. And they go through it because somebody's told them it's a good idea and they'll do it. And then next thing you know, they're digging their generator out of their back. It happens. So being able to pre-select some of those patients out, I think, is very important. And that's where having a good relationship with your neuropsychologist as well. I highly recommend a neuropsych eval before any of these things. They can help peel some of that out, as well as anxiety and depression that may be so overwhelming that no matter how much benefit you're getting on a neurologic level, you're not going to see the same clinical benefit because it is a very subjective experience of pain. Having those conversations, having a good relationship with somebody that you trust to weed that out. I'm not as big of a fan of these just online questionnaire neuropsych evals. It's not a box to just be checked off to be able to implant. I think it is a very important step to implanting with neuromodulation.
So for effectiveness, it's patient selection, but also the experience of the neurosurgeon, which having the resources, like being part of the societies, and as you mentioned, the cadaver courses, having the mentors really seems like an essential part of and piece to this puzzle.
Yes. I constantly am calling either Dr. Peterson or Dr. Conrad or any of them anytime I have a patient that I think that this may be an option, but I'm not sure. It's nice to have that relationship that you can bounce ideas off of, who have had more experience than you, may have had a similar case, and who may know an up-and-coming therapy that I don't know about yet to offer to those patients, or an old therapy. And I've sent a couple patients to Dr. Conrad for DRES because I've never done DRES, but I know about it because of a course here that I took at NANS, and he's done it. So I can send them to him, and then he's going to let me scrub in once we actually get one on the books so that I can learn how to do it. And if it weren't for NANS, I would have never had that opportunity.
That's wonderful. On our website, neuromodulation.com, we have a list of all of our members who have experience in these types of therapies. Are there any misconceptions or myths about neuromodulation, aside from what we've talked about with patient selection and experience, that you'd want to address?
So a lot of my partners when I started had this idea that if a patient needed a big spine surgery but wasn't the perfect surgical candidate, they should try spinal cord stimulation first. No. No, I don't find it very helpful with mechanical back pain. It does help with neuropathic pain. It is possible to help some of their pain, but they'll never be satisfied with the outcome. And then they're probably still going to need the big spine surgery down the road. And now if you go use a Bowie for that, you're going to fry their battery most likely. So then you either have to use a plasma blade, or what happens more commonly, the neurosurgeon just removes the spinal cord stimulator, does the surgery, and then they don't ever even have that opportunity down the road.
Yeah, that's a lot of important considerations. Could we take a minute to just talk about your foundation?
Sure. So I started the West Virginia Movement Disorder Alliance. When I came to West Virginia, one of the biggest concerns my neurologist had about the way that I did surgery was that it was over 3 stages, where the previous surgeon did it all on the same day. And I explained how when you treat one side of the brain at a time, you reduce the risk of having side effects such as swallowing problems, speech problems, and balance problems. I thought that was the safest way to treat it. And he was really concerned that our patients would have difficulty just coming in for all the different appointments and the 3 stages of the surgery. And I told him, I said, somebody's financial ability should not dictate their medical care to the point that you're jeopardizing their outcomes. And so I worked with some friends of mine in the area, and we created the West Virginia Movement Disorder Alliance and started raising money so that we can help patients with things like rides to their doctor's visits. We've built a ramp for a patient who had a scooter, but he could never use it because he couldn't get it in and out of his house. So he could only use it around in his house. We were able to build that ramp for him now, and so we've significantly increased his mobility. And another patient needed some glasses because his movement disorder affects his eyes, and he needed special prism glasses, but he just couldn't afford them, and his insurance didn't cover all of them. So it's been a blessing to be able to do that. But on top of that, we're also providing educational links through our website about these different disorders. And we have highlighted all of our community, like Rocksteady Boxing and the Paddleball Club in Charleston. And it's really a statewide organization. It's not just for my patients there at Marshall. This is open up to all the patients in West Virginia and Southern Ohio and Eastern Kentucky. Whoever needs the help, we're there for.
That's wonderful. It sounds like it's really grown then.
Yeah, it's not quite 2 years old, and so we've done a lot of good. We're working hard to get it even bigger.
That's awesome. Where do you see neuromodulation going with advancements in technology specific to the neurosurgeon perspective?
I think it's going to work us out of a job.
Okay, so you did mention that.
My hope is that one day we won't have to do surgical procedures for these disorders, that we will be able to treat these patients without implantable devices, whether that's just stereotactic implantation of drugs. Light therapy is coming a long way. So there's some interesting things out there that I think will lead us to a place where we don't have to implant. But thankfully, it's several years away.
Who would not be a good candidate to pursue neuromodulation?
Somebody with a lot of comorbidities, like your COPD smoker who's had 2 heart attacks and on aspirin and Plavix and has to keep continuous oxygen on. That's a patient that, if they're in severe pain, sometimes I'm able to offer them a percutaneous implant, but even so, that's done in a prone position with a little bit of light sedation. And anesthesia gets very nervous about, especially a heavyset person in that position, giving them any kind of sedation. Those patients typically have to say, I don't know that this is the best option for you.
As far as neurosurgeons who would not be good candidates to pursue a career in neuromodulation, you mentioned you have to work hard and you have to be able to see the light all the way at the end of the tunnel.
Yeah, you shouldn't go into neurosurgery if you can't do all of those things. There's not many neurosurgeons that I would say cannot do neuromodulation. But if you're one of these people that every time somebody complains about pain, you get really irritated and you just shut down and you don't want to talk to them anymore, neuromodulation is not the field for you. We often joke that it's not a normal clinic unless somebody at least cries at one point during their interview during clinic. There's so much emotion that gets built up with chronic pain. The idea of a hope of that going away will often bring tears, or just talking about their pain will bring them to tears. And if you can't handle tears, you don't need to be doing it.
I'm going to switch gears just a little bit. I know that you are the former social media editor for our journal. Could you talk a little bit about how the journal and those resources have helped to provide education on emerging technologies and research to help, in addition to the mentorships that you've had in your work?
That was a wonderful experience. One, it made me read more articles, right? Because for each articles that the editor selected, we had to create a PowerPoint or a little doodly video about it. So I got to read some of the top papers, or was really forced to read those top papers and really dive into them and dissect them to be able to create that. That kept me up with the leading things coming out in the literature, as well as built a lot of social media relationships that I wouldn't have otherwise had. There's so many med students and residents that have reached out through social media asking questions that I don't think I would have had access to otherwise without that venue. So it was a very, very rewarding experience.
So what I hear you saying, if you want to pursue neuromodulation as a neurosurgeon, reach out. You don't even have to go have someone in your institution. It's as simple as reaching out online, that people are accessible and they want to help.
Yeah, definitely look me up on social media, send me a message. Happy to get you involved however I can. NANS has a great mentor-mentee program, which I've done, and Danica Paulo was my mentee this past year, and I've gotten to meet up with her here at NANS. That's been a great way to build relationships and now start to be on the other side of it a little bit and get to pass things down as well.
That has to be extremely rewarding.
Yes.
And just because we do have a global audience, being the International Neuromodulation Society, I should mention that we have a global mentorship program as well to really help budding neuromodulators. I have just learned so much in this discussion with you. Is there anything that you would like to add?
We've covered a lot today.
We have. And we know that if anybody has questions, to contact Dr. Pinckard-Dover on social media?
At PinckardMD.
There we
On
go.
Twitter is probably the easiest one, or LinkedIn.
Wonderful. Thank you so much for joining us and sharing your insights. It's been really valuable conversation for our audience to hear.
Thank you very much. It's been a pleasure.